I'm always wondering, who's looking at my hair? Does somebody notice?
It has affected my personal life in lots of ways. My self-esteem, well, let's just say I'm very conscious of it. I wear lots of wigs. I felt really bad about it, and I started slowly going into a depression over it, but I kept it covered so I wouldn't have to see it.
As dermatologists, we understand the emotional impact that hair loss and hair disorders have on our patients. So what we've done is put together hair experts from the Skin of Color Society. The Skin of Color Society specializes in all conditions, hair and skin, in patients with darker skin types. Hair tends to be a very, very important issue to us. So we have our experts, and we're here to talk about hair disorders in patients with skin of color. So let's talk a little bit about how our patients present to our office and how we as clinicians go about diagnosing them as well as making some recommendations. What are the history? What are we looking for? Andrew.
Yeah, when I'm presented with a patient who's coming in for hair loss or hair concerns, I like to emphasize right out of the gate that hair loss is a very complex problem. It can be due to something external, like due to your hair care practices, or it could be a sign of an internal medical disease. I've diagnosed lupus, thyroid disorders, other important medical conditions just based on hair examination. So when I actually look at the patient, I want to determine, is this a problem that's external or internal, if you will? And when looking at the hair itself, I like to differentiate between hair breakage versus actual loss of hair.
So that's important. When patients come in, they always think of hair loss, but there's hair breakage, there's hair thinning. And so what are some of the common symptoms or signs that you listen to from your patients when they're concerned about hair problems?
Well, one of the things that I do when I think about hair breakage is, are you having hair coming out by the roots, or are you seeing fragments? When you see fragments of hair, then that's usually going to be breakage.
Do you do a hair pull test?
I do a hair pull test. Usually we think about a hair pull test being about 30 hairs between your thumb and forefinger, and you pull from the root to the tip, and you see what happens. And a lot of times you'll have significant numbers of fragments, but when you have hairs coming out by the roots, then that means that there is a form of true alopecia. And that brings us to this question of what is alopecia really? Alopecia is all of hair loss. It's the 2,000 or 3,000 forms of disease that can cause hair loss on your scalp. And a lot of our patients come in and they hear this word alopecia, and it means different things to different people, but it really is the overarching term of hair loss. And then within that, or under that, there are many different forms of hair loss, different forms of alopecia that can be diagnosed by your dermatologist.
So when you say different forms of hair loss or alopecia, are we thinking about the two separate categories? Non-scarring, where the scalp looks normal, versus the scarring, where the scalp can be inflamed and irritated and look scarred. Do you have patients that present with certain symptoms?
Yeah, absolutely. So just like Dr. Alexis said, a lot of times I'm looking at a patient, I'm thinking, is this something that's coming just from the scalp, or is this something that's coming internally, right? So if it's coming just from the scalp, I'm looking for signs of redness, I'm looking for flaking, I'm looking for maybe pus-filled bumps. And then I can say, okay, this is a scalp-focused or scalp-centered issue. If it's coming from internally, I'm looking for other signs of hair loss in other places, like have you also lost hair in your eyelashes? Have you lost hair in your eyebrows? That might be a sign that you have a condition called alopecia areata, which is an autoimmune condition. And so I may talk to the patient about a family history of that type of hair loss. I may talk to them about whether or not they're feeling more tired than usual. So those are all really great questions to ask patients when they come in. And then to Dr. McMichael's point, I'll tell patients, I'll say, look, there's a difference between having a scalp issue and a hair issue, right? So your scalp may be totally healthy,
separate.
But once your hair exits the scalp, if it's starting to break, that's a hair issue. So doing things like a scalp biopsy may not be helpful in those instances, right? Because if I take a sample of your scalp, I can just see what's happening in the skin. But if you're getting breakage just kind of at the tips, it may be a sign of poor hair care practices.
Can you explain about that term, scalp biopsy? That's a diagnostic tool.
Absolutely.
What happens in the doctor's office in the exam room when they're going in for a scalp biopsy?
Right, and this is a great question because this is what a lot of my patients are scared of. So I have a lot of patients who will come in and say, you know,
they're scared.
I would have come in 6 months ago, but I was really scared about something called a scalp biopsy, and I had a friend who had it, so can you tell me more about that? And basically what we do in a scalp biopsy is we'll numb up the scalp, and we'll take typically 2 very small samples of the scalp so that they can be sent off and analyzed underneath the microscope. You know, I reassure my patients that the scalp doesn't have as many nerves as, let's say, the fingertips, so people tend to do very well. It's a very quick procedure, and a majority of patients actually get hair regrowth through the area that's been sampled. So it doesn't cause permanent hair loss. And this is very important for our patients who are coming in with hair loss. If we tell them we're going to take more of your scalp, we also need to reassure them that we expect hair to regrow in that area. And so this is really very important to help us make a diagnosis and shouldn't affect their overall outcome.
What is the most common hair disorder that you see in your practice, Dr. Burgess?
Well, I get an assortment of different diagnoses, and a lot of times the patients have gone to other dermatologists, and I may be the 4th or 5th dermatologist that they see. And what I find out from the patient is they just looked at the patient and said, oh, you need something for dandruff, or you need Rogaine, or something like that.
Or you just need to put a wig on.
Exactly, or we can't do anything about the condition that you have. So I see a lot of follicularities of the scalp, which are truly scalp issues and not just androgenetic alopecia, in which they always get the Rogaine for. But what I try to stress to the patients is that not all board-certified dermatologists specialize in hair, and it's very important to seek out that type of person because we're going to spend a little bit more time with them getting the history. As Crystal was saying, we're going to assess the scalp and the hair and what have you. And one thing also about the biopsy that we were talking about is there's a standard biopsy that should be taken. And I ask patients, where was the biopsy taken? Oh, it was just here. But we try to take 2 biopsies, and we try to take one in the androgen stimulated area and the non-androgen stimulated areas. So one on the top and one in the occiput.
So the dermatopathologist
can compare it, and there's a standardized 4mm punch size, and where they know the calculation of the anagen to telogen ratio, and I always ask my dermatopathologist to give me that information so I can further diagnose what's going on. So there is a specific international way of how we do a biopsy, and unfortunately they don't go to someone who has a specialty in hair. Sometimes they'll do a 2mm or 3mm, but we know we need to do a 4mm. It's just too small to get the averages of your anagen and telogen ratio.
So we talked about hair loss, and we know that with women that is a major issue: hair loss, hair breakage, seborrheic dermatitis. But what about males? What about men of color? Andrew, can you tell us some of the most common forms of hair problems that men present with to your office?
Yeah, particularly men of African ancestry present with some specific hair disorders that disproportionately affect that population.
What are they?
Number 1 would be acne, keloidalis, nuchae, that the general public might just call hair bumps.
Shaving bumps.
Shaving bumps.
Back of the scalp.
Even though technically they may not have much to do with shaving, but what they are these very hard keloid-like bumps on the back of the head. But sometimes you can see them further up, even up in the crown, and in severe cases can actually cause permanent hair loss, scarring alopecia. Picking, scratching, irritation from close haircuts from electric clippers may be exacerbating factors, although it's debated how much that plays a role in it.
So that hair grooming plays a role, right?
That's right.
Plays a lot in
yeah,
this
so I
condition.
do advise patients to minimize the very close haircuts, so minimize irritation from electric clippers. Avoid picking, scratching,
What about
tight-fitting
treatments?
hats.
What about treatments?
Now, when it comes to treatment, we use intralesional corticosteroids, so injections of anti-inflammatory steroids right into the bumps. Topical yes, that causes them to flatten, soften. Topical antibiotics, oral antibiotics, especially doxycycline, which has anti-inflammatory effects, is very helpful, and topical steroids.
Okay. So what do we recommend for our patients who present with hair breakage or sebderm? What are some of the new treatment options, or even the old treatment options?
Right. Well, you know, seborrheic dermatitis is one of those things that is confusing, I think, in and of itself, because people don't know the difference between dandruff and seborrheic dermatitis. And if you put a group of hair-interested dermatologists in a room, they can actually fight over that for about an hour. So I'm just going to lay it down and say, for my patients, I tell them that dandruff is just a mild version of seborrheic dermatitis. We call it sebderm for short because we shorten everything in dermatology, and seborrheic dermatitis is going to be the way I refer to it. So seborrheic dermatitis is a condition where you get scaly, flaky, itchy scalp symptoms, and it's typically not related to some underlying skin or systemic illness. It's really related to the scalp. It's very prevalent, very, very common in patients who are of African American descent. In one study, it shows that African Americans had the highest prevalence of this disorder.
Is that the women?
The women and men actually had it. So, and I think that it's probably a genetic process, but it also may have to do with the fact that oftentimes hair washing or hair frequency is fairly low, especially in women of color. But I don't think it's caused by that. I think it's really mostly a genetic thing. So when we treat that, we take the inflammation down. As Dr. Alexis pointed out, we do use topical steroids to take down inflammation. And in this disorder, I think it has a very big role. I think frequency of hair washing can be discussed. In my practice, I recommend for people to wash their hair either every week or every 2 weeks, and that's the contract that I make with my patients.
And you should
that I take care of that every week to every 2 weeks minimum, and that doesn't.
And this is for women.
Right, for women. It doesn't
right?
matter what kind of style you have and what your stylist has told you the frequency should be. The stylist is not a dermatologist and doesn't see the breadth of scalp disease that we see. So every 2 weeks, even if you don't wash the ends, you get that scalp cleansed, not with a dry shampoo, but with a real shampoo, one that's formulated preferentially for people with skin of color.
Yeah, and I always recommend an antifungal shampoo.
I like that too. I do.
I think they can take it with them to the hair salons.
Yes.
And they can use it and bring it home.
Yes, I like zinc-containing shampoos, and I think now there are many that are moisturizing. It's very, very difficult to have a cosmetic chemist put together a medicated shampoo that can also be moisturizing, but these do exist now. And so when you go to your dermatologist and they know how to take care of hair and skin of color, they will tell you which ones are appropriate. And so that's the start. The topical steroids, using them in a tapering fashion, frequency of hair washing, and I think for the most part we can get most people very well controlled with that regimen.
And one thing just to add to Amy, like I will have patients come in and have used that shampoo every day, and they wonder why their hair is breaking.
Actually,
now we know that a week or 2 weeks, but not every day, not every other day. And unfortunately, some dermatologists are telling our patients of color that's why they have the condition, is because they're not using the shampoo as often as, say, someone with straight hair or oily hair or scalp.
And can I segue with that point into why it's important that hair washing frequency is different in straight hair versus curly hair, right?
Oh, yes.
So just to break it down, there's a natural scalp protectant called sebum, okay? It's produced by your scalp. It helps prevent hair breakage. If you have straight hair, that sebum coats the entire length of the hair shaft with every brush stroke. So if you take a brush or a comb, you have that natural protectant everywhere.
That's their natural oil, right? That's correct.
It's a natural hair oil, and this is why people with straight hair feel inclined to wash their hair every day or every other day, because after a couple days, that sebum will attract a lot of dirt, and you'll have to wash your hair. Okay, so sebum is great in limited forms. If you have very curly hair, even with brushing or combing, that sebum gets stuck at that first curl at the top of your scalp, okay? So it means that curly hair doesn't get a natural protectant that coats the entire hair shaft, right? And so we have a range of straight hair to curly hair. In between is wavy, and it gets curlier as you go down the line. When you use a shampoo, shampoos are designed to cleanse, and they are literally designed to remove sebum and remove oil and moisture, okay? And so if you have curly hair and you don't have that protectant anyway, and you're stripping away moisture that you need, that's when you get hair breakage. So a lot of times, you know, what patients have to realize is that hair care is not a part of a natural dermatology curriculum. And so to Dr. Burgess's point, you may see 7 or 8 dermatologists who are well trained in skin disease, but have never learned about the hair. And so they have the best of intentions when they're giving you a prescription for an anti-dandruff shampoo that is meant to, again, remove all that moisture and oil and grease that makes people with straight hair feel great, and they don't realize that it may damage the hair. So your scalp may look better, but then your hair won't feel so great and it'll break. And so that's why it's important, as dermatologists, we're trying to educate our colleagues as well, but certainly get that message out to our patients that it's really a fine balance. And I do the same thing as Dr. Michael. I really like a once a week hair washing, because hair washing, especially with a good conditioner, is adding in the moisture, that natural protectant that our scalp unfortunately is unable to provide to us, at least to the rest of our hair.
Right, and there's also just an innate fragility to hair in patients of African descent.
It's curly.
Yeah, we
Absolutely.
have not figured that out, you know, but there is that innate fragility, and so add that to this issue with less sebum protection, and I think you do have a recipe for breakage if you are not taking good care of the hair. And so for a lot of my patients, I tell them, put the anti-dandruff shampoo to your scalp and use a more moisturizing shampoo on your longer hair. And then follow that, you know, once it's washed off, follow that with a conditioner. And many conditioners now have actives in them. So zinc-containing conditioners are now available, and that can be helpful too. So and then I go even further than that and say use a coating agent on the hair shafts, like a dimethicone containing coating agent, and that can be a protectant. So there really is a sort of a regimen that has to be given to the patient in order for them to understand how to care for their hair.
Hair grooming is very important.
Absolutely.
Okay, and there are cultural issues too that we have to understand.
Yeah, and one other point, we talked about a common misconception among dermatologists and others who are presented with patients who have hair problems, but a big misconception among patients in the community at large is when they notice that their scalp is flaking or itchy, their first response is to add oil to the scalp because visually it looks dry. Therefore, add an oil-based product to address it. Of course, that masks the problem and doesn't address the underlying condition, seborrheic dermatitis. So I do spend a lot of time educating my patients that we are going to treat the underlying scalp problem with the medicated shampoos and the topical corticosteroids, etc. But when it comes to adding oil or moisture, that's for the hair, not for your scalp.
Correct.
So
Or
I differentiate.
Exactly.
So differentiating greasing the scalp versus moisturizing your hair.
Right.
Treating the scalp with the medications and treatments that we recommend, but addressing the dry hair problem and hair manageability issues separately. So differentiating what you do to the scalp to the hair.
And one thing we have to combat as well is the fact that a lot of our patients are going to be having like weaved extensions that they may leave in place for 3 months. So how do they get to the scalp every week, right? And so there's going to have to be a shift in hair care practices, especially for these patients with really bad dandruff, you know, and even wigs. Many patients are gluing on wigs and leaving them in place for a month or 2 months, and so that's an issue.
So that brings us to another topic. Wearing these wigs and the weaves to cover up the problem, you know, we need to address that actual problem and the diagnosis. So like with alopecia, what are some of the treatments that you're recommending? There are different types of alopecia. What do you recommend?
Right, and again, as you said, alopecia is a very general term, and I try to explain to patients that if I say automobile, you know, I'm not talking of an airplane, but you don't really have any idea what I'm talking about. So we need to get a history. We need to determine what type of alopecia it is. And generally, alopecia is not a word that stands alone. It's usually tagged with another word. So once we find out what type of alopecia they have, if it's something like alopecia areata, currently I am doing some studies that, and I think you are too, Val, on topical JAK inhibitors that actually help to promote hair, help to kind of combat that autoimmunity that's going on with alopecia areata.
Because we've always used topical
injections or corticosteroids, but now there's other treatments that are soon to be available, and we're seeing some promising results of these studies, and so we're looking at possibly in 2019, 2020 when these products and prescriptions will be available.
And so one of the things to clarify, you know, alopecia areata is a very hot disease right now, and the reason is that there was a large registry of patients, over 10,000 patients, who gave blood and some scalp biopsy samples that allowed researchers to figure out the mechanism of this disease. That's the only one we've done that for so far. And alopecia areata is actually very common in all ethnicities, and there is no increase that we know of in skin of color patients. But sometimes we see that it's missed in skin of color patients because it can present very differently in different patients. So usually you'll see patchy disease, patchy loss of hair, with the hair follicle still intact, but a lot of times it can go to involve the entire scalp, the entire body, with zero hairs on the body. And so when you're talking about alopecia, I just want to clarify, that's the kind of hair loss we're talking about when we say alopecia areata, and that's the one where these new treatments, based upon the research that's been done, is coming to the fore now. And you know, many of us are doing those very exciting studies. We've got great drugs being developed based upon all of the science that was done, but that's unfortunately the only one where we're at that level. There's so many other forms of hair loss, many of which are scarring. We talked about alopecia areata. That's one of what we call non-scarring alopecia types, where the hair regrows if you can find the right trigger to make it grow. There are some others where the inflammation that Dr. Alexis talked about actually destroys the hair follicle down in the skin.
Those are the scarring.
Yeah, and those are the ones.
Those are the tough ones.
Yeah, we really need a lot more research and a lot more work.
Okay, so when we think about scarring alopecia, we all know about central centrifugal cicatricial alopecia, or CCCA, but what about the increasing frequency of the patients who present with frontal fibrosing alopecia, FFA, which was originally thought to occur only in postmenopausal Caucasian women. But we do know that it's also seen in all ethnic patients. Tell us a little bit about FFA.
Yeah, so just by way of background, FFA, frontal fibrosing alopecia, presents with loss of hair in the front and temporal areas of the scalp, often with loss of the eyebrow hair too, which is an important clue. It can be a bit difficult in the early stages to differentiate from traction alopecia because it has a very similar distribution. But looking at loss of eyebrows and looking at sort of a complete loss of hair along the margin of the temple helps to differentiate traction versus frontal fibrosing. I agree, it's on the rise. We don't know why. And I'm seeing it at younger and younger women than I did when I started seeing patients.
What are some of the treatments for FFA?
So FFA is, I think, depending on the dermatologist, yes, they'll consider a variant of another hair condition called lichen planopilaris. Under the microscope, they look identical, but lichen planopilaris can affect any part of the scalp, whereas frontal fibrosing affects the front part of the scalp. And my mainstay of treatment is anti-inflammatory medications, whether that's a steroid cream, a steroid injection, something like Plaquenil, which was initially designed to be an anti-malarial drug, but is now being used for a lot of inflammatory and autoimmune conditions. I've also recently started using something called platelet-rich plasma therapy. Platelet-rich plasma therapy initially—
Is that PRP?
PRP, thank you. Yes, initially kind of came to medical significance in the orthopedic surgical field, actually, for these doctors would inject it into the joints to decrease inflammation, slowly made its way to plastic surgery for kind of scar rejuvenation and dermatology, and more recently has been used for hair loss. And so I have been treating my patients with PRP and have seen that some of my patients with FFA and lichen planopilaris have been some of my best responders. Now again, This is a condition, the earlier you are seen by a dermatologist and diagnosed, the more likely you are to respond to treatments. And so both lichen planopilaris, frontal fibrosing alopecia, CCCA, they all hit this terminal point that I like to call end stage disease, where there's so much scar and so much hair loss that it's difficult to get any hair to come back. But in early stages, I think that many of these patients have a potential for regrowth that some of us underemphasize, and it's important for patients to know that there is hope for them.
Yeah. So it's very important to treat the disease aspect of it first, and then the hair growth. At least now we have some things that, like PRP, that can help. But also there was a recent article in using isotretinoin or Accutane in some of these patients. So PRP, as you know, is kind of expensive, and just to explain how that process is, we draw the blood from the patient and then we re-inject it into the scalp, and patients, you know, think, oh, okay, that should be pretty easy. I go get my blood drawn, but there's certain type of blood tubes that we have to use, and so it kind of drives the cost up, and a lot of people may not be able to afford it, but they may be able to get a preparation that's a prescription to at least control the disease. So now we have two aspects of it, the more cosmetic side of it and the medical.
So there are newer treatments. So we do have our old medical treatments. We also have some of the new treatments. So in summary, let's kind of have a call to action, some clinical pearls or some practical tips for our patients. I think it's real important that we talk about the quality of life and the treatments, but if you had to just say one point that is so important for patient education, what would you say?
I'd say that one of the most important points is early diagnosis, because with a lot of these conditions, especially the scarring alopecias or scarring forms of hair loss, the earlier you catch them, the less likely you are to have large areas of your scalp permanently damaged and with permanent hair loss. So it's the most rewarding thing that I ever have with my hair loss patients is when I catch it very early, where the majority of the follicles are not yet scarred, and we can salvage the viable follicles, stop the scarring alopecia in its tracks, and promote regrowth. That's a very satisfying day. So early diagnosis.
Patients need to get it to see their dermatologist.
That's right. And I think that the very important thing to note is that at least start with a board certified dermatologist. There are a lot of people out there who deal with hair and scalp. There are a lot of people who are called trichologists, and that can be, you know, a lot of different things in a lot of different states, different countries. There are hairdressers, stylists, etc., and they all have some thinking around hair and hair loss, but most of them don't have the medical training that a board certified dermatologist has. So what you want is somebody that understands what's going on, from the science of the anatomy to the physiology to all the latest in prescription availability to evaluate you for your hair loss, and that's where you want to start.
Okay.
I think my main point would be hair care. I really want to empower patients to feel comfortable taking care of their hair. So if you come in with a scalp issue and we give you topical steroids and we get your hair to grow back, but you have, you know, you're wearing a wig every day and you're not cleansing your scalp properly, you're not conditioning your scalp, you're not using a leave-in conditioner, you're not doing protein treatments, you will continue to notice hair breakage, and you may continue to be dissatisfied with your overall outcome even though your medical condition is in remission. So again, just like Dr. McMichael said, you know, shampoo with the sulfate-free shampoo once a week. These tend to be more gentle to curly hair. Follow it up with a conditioner. Ideally, if you can, deep condition every time you wash. That's applying a conditioner under some sort of heat source, whether that's a hair dryer that you sit underneath, or just putting a shower cap or a warm towel.
Occlusion.
Exactly, and then following it in with a leave-in conditioner, which should ideally be applied 3 to 4 times a week, particularly for women with the curliest hair who are completely natural, or if they're color treated or have relaxed their hair.
Okay, Dr. Burgess?
So I want to piggyback on Dr. McMichael in that, yes, definitely see a board certified dermatologist. However, not every board certified dermatologist specializes in hair. And not all board dermatologists who specialize in hair specialize in our hair. So it's very important to seek out those who have the know-how and the expertise, knowledge of how to work a patient up, how to do scalp biopsies correctly, that know how to deal with our hair.
Okay, and I would just add that there are medical treatments, there are cosmetic treatments, and we didn't talk about surgical treatments, but there are options. And so it's very important that we all diagnose our patients and help them with their quality of life and their self-esteem, because we know that that's a very important issue to them. This discussion was great. It's going to help a lot of our patients, and I really appreciate all your expertise. And of course, the expertise is from the Skin of Color Society. Thank you.
Thank you.
Thank you.